Good afternoon, and welcome to yet another Born Ontario briefing. It's 12:01, and we have a fair bit to cover today, so I think we'll get started. My name's Mari Teitelbaum, Acting Director of Born, and this briefing is all about the Born committees, the Born committee structure, focused on a couple of the committees and their work. I have a couple of co-presenters with me who I will introduce shortly. So, Born committees. The committee structure within Born was pulled together, I think, about 2 years ago. This work began, recognizing the need to be able to be advised by experts provincially, and also have a mechanism to inform others in the province of our work beyond this type of forum. And so we began a couple of years ago brainstorming what type of committees Born would need to be successful, and worked very closely with PCMCH, with the Provincial Council for Maternal Child Health, on this initiative, recognizing that they already have a number of expert committees that inform the policy associated with maternal child care. So through that evolution, we actually ended up following a couple of models to build committees to help us with our work. You'll notice on this slide, we've tried to illustrate those two models in a single place. But essentially, our maternal child screening committee, along with the prenatal screening subcommittee and the newborn child screening subcommittee, were the first set of committees to come online. And that has joint reporting to the Provincial Council as well as to Born. So there's a team that meets representing those three organizations to share information and keep us all aligned. That committee first met a couple of years ago, was chaired by Joe Clark, with close contact to those two subcommittees. And we're going to do a follow-up session, another Born Ontario briefing about the work of those committees. They're incredibly busy doing some amazing work, but it would easily take an hour just to touch on screening. So for this week, we won't be getting into screening, but we will be focusing on these other Born committees, the Maternal Newborn Outcomes Committee and the Ontario Congenital Anomalies Committee. These committees report to Born, work with Born in their work. The way we stay aligned with the Provincial Council for those two committees is to ensure joint membership. So we try to ensure that someone on the Maternal Newborn Outcomes Committee sits on the Provincial Council or one of its committees, and the same is true for Congenital Anomalies. So we want to make sure that our work is aligned with the policy work happening over at the Provincial Council. Obviously, subcommittees and even working groups under those subcommittees are required. And again, we'll go into detail on each of the committees and the work of the subcommittees themselves. Those subcommittees come and go as needed. The Maternal Newborn Outcomes and Congenital Anomalies Committee are formalized with very formal membership procedures to make sure that there's calls for members and that we have appropriate subject matter distribution, appropriate geographic distribution, things like that, while the work of the subcommittees and the working groups is a little more ad hoc and time limited as required by the project at hand. So I'm not the best person to speak to the actual work of the committees, and for that we have some people who are linked very closely with Born, but also have a huge role in the committee itself. And what that is each committee has a resource person, a subject matter expert that works with the members of the committee to understand the needs of the committee and drive the work, drive the deliverables of the committee forward. So Dr. Anne Sprague, who's Born's scientific manager, is a resource person on the Maternal Newborn Outcomes Committee and is going to walk you through the membership, the scope, and the work of that committee. And Sherry Kelly is the resource person on the Congenital Anomalies Committee, and will do the same for that. So the rest of the flow will be the work of those two distinct committees. I'm going to come back at the end and let you know how you might get involved if you do have an interest. And then, as usual, there's an opportunity to ask questions through our chat box on the top left. I don't think we have a quiz in today's presentation. So with that, I'm going to pass it over to Dr. Anne Sprague.
Good afternoon, everybody. And although I'm the resource person for the Maternal Newborn Outcomes Committee from Born, there are two a chair and a vice chair who are part of this committee, who I'll introduce in a minute, and are also, one of them may be available with us online today to answer questions. So as Mari pointed out, we actually have this. How do I change the slide? I'm just going to change the slide, sorry. Sorry, just a minute here. Trying to change the slide. Okay, scope. So this is the scope of the Maternal Newborn Outcomes Committee, and it was set up to provide scientific, health system, and technical leadership advice to Born Ontario. So within the Born Ontario team, there are certainly people with different levels of expertise and different types of expertise. But the idea was that this committee would be able to actually give us the direction we need to go forward with some of the initiatives of Born. And our mandate really is to think about the issues related to pregnancy, birth and postpartum care, neonatal issues, maternal health issues, social determinants of health, and outcomes. And that's what really the type of expertise that this committee has, and that they can provide the, as I mentioned, scientific, health system, and technical leadership to Born. The actual MNOC committee membership, see we have a little bit of misalignment here, but is from around the province. Graham Smith, Dr. Graham Smith in Kingston is the chair of that committee, and Dr. Joanne Harold is the vice chair, and I believe Dr. Joanne Harold is online with us today if we have specific questions that need to be answered. We have representatives from midwifery, pediatrics, laboratory services, health economics, obstetrics, maternal fetal medicine, administration, public health, epidemiology, neonatology, perinatal epidemiology, and nursing. So the committee is, and lots of these people's names you'll recognize, but the committee has a good deal of expertise on top of what's happening. Underneath the MNOC main committee, there are two subcommittees, and you saw those listed in the diagram before, was the dashboard subcommittee and the neonatal subcommittee. And the dashboard subcommittee includes some of the members from the bigger committee, but also has gone outside to find other areas where we need expertise. And certainly you can see here, these are people that have a degree of expertise in the quality issues that we're looking at in relationship to the dashboard that I'll describe in a few minutes. And similarly, the neonatal subcommittee, and I'll go over the work of that committee shortly, also has, again, some of the people from the MNOC committee, but then more people externally who have expertise in the work that needs to be accomplished from that subcommittee. So these committees have been formed. They are now working, and Britton, can you switch? Never mind, I got it. There. So to start back with the MNOC group, we've met 4 times in the first year of the process, and you can see here we've had 2 in-person meetings. Most of our business is conducted by conference call. The progress to date from the MNOC committee is we did finalize the terms of reference for that group. The 2 dashboard and neonatal subcommittees have been established. As you can imagine, it's a large amount of work just to set up these committees and get the people engaged and get everybody. The biggest challenge, of course, is getting everybody in one place at one time with everybody's busy schedules. The first specific MNOC projects have been scoped and preliminary data pools started, and we are doing seeking some guidance from different groups around the province on what would be the most helpful from informing both policy, practice, and research. And so, as we mentioned, MNOC is there to provide the scientific, health system, and technical leadership, and these are the areas, based on what the research we've done to date, where we feel that we could make a big difference by digging deeper into these areas. So certainly everybody knows that increasing BMI is a particular clinical issue and a lifelong health issue for women and, of course, their children and families. And so we're looking at the possibility of some economic analysis associated with that. We have the good fortune on our committee to have a health economist attached to us and want to be able to use that expertise. So what does it actually mean? We know that there are poor health outcomes associated with the increasing BMI, but what, in fact, is the economic association with that? And I don't just mean direct costs. I mean, both short-term and longer-term costs, both for short-term and longer-term health issues, as well as what happens in the system. And, ideally you'd like to do some kind of intervention study associated with some of this. So what would the economic outcomes be if you had one type of intervention versus another, and comparing those? Not sure what we can do in regards to increasing BMI, as it is certainly a very, very complex issue, but we're looking at that now. We're also looking at an economic analysis associated with the issue of repeat elective cesarean sections at less than 39 weeks gestation in low-risk women. As you know, some of you know that's going to be one of the indicators we'll be looking at on the dashboard. There has certainly been some information in the literature about the outcomes to newborns associated with that, and spending time in ICU and having feeding difficulties, etc. And so, is there a costing thing that we can do associated with that? We're looking at that. And then just the whole issue of fertility treatment and pregnancy outcomes and, cost economic analysis associated with that. So we haven't made a decision on that yet, but it's taken us a while to narrow down our choices and get to these places. And so, as I mentioned, we are doing some consulting about that. Other MNOC tasks that the committee has to look after is establishing a data element review cycle for the maternal newborn data elements in the BORN system. So as you know, as the BORN system goes live this fall and early next year, we will be, we've done quite an extensive process to look at those data elements, to revise the data dictionary. But down the road, all of you will have the opportunity to say to BORN, you really should be collecting this particular issue or item, or this particular data element would be a good addition because, it will inform these other outcomes. And so, at some point, BORN has to have a pretty rigorous process for establishing these new data elements or retiring data elements when we find there's problems with data quality that perhaps couldn't be fixed, or we've just, get rid of the life cycle of a particular data element. So, part of MNOC's task will be to establish that data element review cycle. And we've talked in the committee about, how we're going to make those decisions and the process by which that will happen. So that's another MNOC task. And then certainly this group helps us consult on performance indicators for the maternal newborn system on a go-forward basis. So that's really the work of MNOC to date. And as I mentioned, with this data dictionary and data elements, BORN currently collects identifiers, health status data elements, risk factors, the care that's provided, which then leads us to outcomes. And so in any one of these areas, we will want to make decisions about data elements that we should be collecting. And those data elements will have to be readily available to people entering data. They will have to inform the outcomes, and they'll have to be important. And so that's the process, as I mentioned, that we're going to start looking at. So there are two subcommittees of MNOC, which I've mentioned. The dashboard subcommittee is the first one. This subcommittee actually predated BORN and was established by the BORN Scientific Committee and then moved over to MNOC. And we've done a fair bit of work. Sandy Dunn works with us on this and is leading the dashboard project, and has done a lot of work in scoping what a dashboard is actually meant to do. A dashboard is a performance measurement tool that incorporates the following functions. So you can see here that there's a feedback function, a benchmarking function, and a warning or signal function. And why it was important for us to consider this is just because of the whole aspect about quality. And the new legislation in Ontario, the Excellent Care for All Act, says that every healthcare organization shall establish and maintain a quality committee for the healthcare organization. And that committee actually, there's a number of tasks, but the one specifically that I pulled out here was to monitor and report to the responsible body on quality issues and on the overall quality of services provided in the healthcare organization with reference to appropriate data. So I think in the maternal newborn child area, we are well set up to be able to be leaders in quality in and amongst certainly hospital organizations, midwifery practices, et cetera, because this system that we have going forward, so the birth record system that we currently have, the NIDA system moving into born, and the data elements that we have in the newborn system are there to help us be able to drive quality. So the dashboard has been used for a variety of purposes within healthcare, but is primarily implemented to drive quality improvement. So the dashboard subcommittee, the progress report to date, and I think we've presented the dashboard at perhaps another born briefing at one point in time, but really it was to choose those maternal newborn indicators that are going to be on the dashboard. So there was a ton of background work that went into that, a fair bit of literature review, and we do have a final list of those 6 indicators that are approved. We wanted to establish, so remember that part of the dashboard for quality is establishing a signal, and so we wanted to have established evidence-informed benchmarks. And just at our meeting 2 weeks ago, I guess, those benchmarks have been approved based on what we found in the evidence, what we looked at in clinical practice, and what was already in the database, because we looked at the data that we currently have to see how we were doing on those things. We also have to, in that committee, develop report specifications for the born system, for the look and the feel of the dashboard screen in born. And we do have some dashboard standard reports, and the visual representation of what that's going to look like is almost complete, which I'll show you in a minute. And Sherry Kelly, who's going to speak to you next, within Born, has been driving all these report specifications and has been very, very busy in doing that. A big thing for us in the committee was to consider the methodological issues about the stability of estimates in low-volume centers. So as much as possible in the dashboard, we've tried to standardize patients. So we're not looking at cesarean section as a whole or rates of cesarean section, because it just varies too much among different centers for various reasons, depending on the risk population they look at. So instead of doing that, we've chosen to look at a very specific population and look at a particular indicator about cesarean section in that population. So that helps to reduce some of the problem in comparing hospitals across the province. But then we're also looking at what's the difference between high-volume and low-volume hospitals and how often we can report on that data. So we're still not quite where we need to be on that. We've had some consultations across different areas, and I looked at other areas who report scorecards and dashboards and see how they manage those things. So we're still working on that. We have to pilot test the dashboard in level 1, 2, and 3 hospitals in the province, and the planning is underway for that. And we have some specific criteria about how to choose those centers. And some of you will be approaching soon about that. And then, of course, because Born has a strong science bent, we're also looking at a research project associated with the implementation of the dashboard across the province to learn a little bit more about best ways to do these types of things and ways to start to see changes in outcome. And so we had preliminary meetings about that, and our grant deadlines have been explored for that. So that's really what the dashboard has been up to. And this is just very briefly a picture of what that might look like down the road. So on the left are the outcomes that we'll be looking at. The individual hospital rate for that outcome would be listed, and then the status based on the status bands below. So I don't know how well you can see this here, but the bottom line is there are benchmarks established for green, meaning you're on target, yellow, meaning, you got to pay attention to this a little bit, and red, meaning there's a bit of an issue in practice. You'll also be able to compare yourself to the same level of care hospital as you, a hospital with a similar birth volume as you, and the province in general. So you'll be able to see those comparisons. So this isn't by any means the final picture of what this will look like, but it certainly is where we're going with it. And so I just wanted to give you that visual today. So that's sort of the work of the dashboard subcommittee. And last, I'll finish with the work of the neonatal subcommittee. So two of the MNOC members, Dr. Prakash Shah and Dr. Joanne Harold, are leading this group. We did have one meeting. We desperately need to have another one. We've got some work to do. The primary tasks for this group are to discuss strategies for collecting data from level 3 nurseries across the province. So Bourne certainly doesn't have all the level 3 nurseries yet contributing data, and there are various reasons for that and very good reasons, but we want to work on a solution to improve that. So this committee is working with us on that. They need to develop some NICU-specific indicators for a clinical dashboard that meets the needs of NICU nurseries across the province. We're going to work with the Canadian Neonatal Network and others regarding neonatal follow-up data. And then we also want to develop a provincial newborn discharge sheet that will be built as a standard report from the Bourne online system. So any healthy newborn going home with their parents at the time of hospital discharge, certain data elements, as long as they're entered into the system about the birth and about the pregnancy, you'll be able to press a button and spit out a report that those parents can then take to their primary care provider for that first visit. Because although across the province some people have systems, many people don't. And so when you go to form that care plan for that new baby at the first visit with the care provider, whether that be a family doctor, a nurse practitioner, or a pediatrician, it would be very helpful for those people to have some preliminary information before the actual discharge summary gets to them. So that's something we're working on as well. Just to discuss the progress on those tasks, as of November, Bourne will probably have a dedicated person and resources in place to work with Level 2 and Level 3 hospitals to develop a solution for improving NICU data collection. I know for those of you who are contributing NICU data to Bourne, that's incredibly important because we want to be able to report from that system and provide you with better reporting, and that means having better quality and better amounts of NICU data in the system. So we're working on that. For the NICU-specific indicators for a dashboard, the committee has been polled for potential key performance indicators, and a preliminary list is established. We're going to go through a Delphi process to vet those, and we'll probably also be seeking help from the broader community of our partners with that. We're going to work with CNN and others regarding neonatal follow-up data. That'll be one of the next tasks. We haven't gotten to that one yet. And we want to develop a provincial newborn discharge sheet, as I mentioned, and the report specification for the well baby one is developed and has been reviewed. And we're now developing one for those babies who actually may spend a night in an NICU, but actually still go home with their parents. So a little bit more data about what happened to them in the NICU and why they needed to be there. So that's really the update of both the MNOC and the MNOC committee with its two working groups, the dashboard and the neonatal subcommittee. And I'm now going to pass it over to Sherry Kelly, who's working with the Ontario Congenital Anomalies Committee, and she'll update you on that work that's happening.
Thanks, Anne. A pleasure to be on the call today. So again, I'm going to be introducing the Ontario Congenital Anomalies Committee. I have to first say that I'm a very new member to this committee, as I started with Bourne, Ontario 2 months ago as an epidemiologist. I'm taking the place of Deshane Fell, who's on educational leave for the next year and who is also a continued member of this committee. So first, before I introduce the committee members, let me just say, in case some of the audience wants a refresher on what congenital anomalies are. Congenital anomalies, this is the formal definition, include the anatomic, metabolic, and other abnormalities that are apparent in utero, at birth, or detected in early childhood. So they're any abnormality or malformation, and they're detected across the birth continuum. So what is the scope of this committee? This is taken from our proposal in terms of references is to provide scientific and technical leadership advice on congenital anomalies surveillance and related activities to Bourne, Ontario. These include developing and maintaining enhanced congenital anomaly surveillance systems, so that being to take a look at the current systems in place and to see how we can improve and enhance the surveillance across the province. We also want to determine the quality of the current data and the scope at which it covers these anomalies, and to continue looking at the case definition for congenital anomaly surveillance. So the committee was established with the following members, and this was back in December of 2010. Dr. Greg Ryan is the chair. He may be on the call to answer some questions later on. Dr. Aideen Moore is the vice chair. They're both from Toronto, and we have membership from across the province, of course, in areas of neonatology, maternal and fetal medicine, genetics, radiology, pediatrics, epidemiology, as well as in newborn screening. We have two members from Born, Ontario, myself, and Heather Ramshaw, who's the newest member of the Born team as the Born coordinator for this committee. It's very important that we had wide coverage of different interdisciplinary fields for this committee, as well as to have representation from across the province, as you can see. So there were 6 meetings held already. The first 2 were in person, and the last 4 were held by teleconferences. As Anne said, that's how we conduct most of our meetings, as all the members, of course, have full schedules. But we're very excited to have our next face-to-face meeting coming up in November, and hope to have another teleconference before that, just to take a look at some of the tasks that we're tackling. There have been discussions about forming subcommittees. The 2 areas of focus are in genetics and pathology. At the moment, there are no common database systems for these 2 fields, genetics and pathology, for data collection, and so it would be a great benefit to this committee to form these 2 subcommittees to take a look at some of these data ascertainment needs for congenital anomalies. So as Anne presented, we wanted to give you an overview of the progress for the Congenital Anomalies Committee. So here are some of the tasks that have been identified, and the process is in the right column. So the committee overall is to advise on the strategy for congenital anomaly surveillance. So this is something that's been ongoing and will continue to be ongoing throughout the committee's existence. We wanted to evaluate additional sources of congenital anomalies data. That's been conducted. So we did an inventory scan of non-hospital data sources. There were 5 different data sources that the committee looked at. These include ISIS, OACRS, CPSP, CNN, and Vital Stats. Again, I hope there's not too many acronyms, but basically these are the non-hospital sources of data. And there were 5 hospital sources of data, just to mention things for transplant, fetal cardiology, transport, and also neonatal operations. And lastly, we took a look at environmental data sources. There were, again, 5 sources of data looking at pollutants and air quality. So this has been reported on the different additional sources of data. So the next thing to do is then to select the sources that we want to incorporate. And this has also been done. The next step down is basically we've chosen 2 additional sources of data, those being CNN or NICU-related data, as well as discharge abstract database data, so that's for improved case ascertainment of congenital anomalies. So these have been identified, as well as to also look at pediatric cardiology data. So the next thing we want to do is, even though we have the current data set and we're going to incorporate additional data sets, we want to assess the completeness and quality of the current data in the Born system. So we are evaluating the FAN, which is the Fetal Alert Network data, as well as the NIDA data. That's something that's ongoing. So the committee is also responsible for advising on allocation of resources related to congenital anomalies. This is something that's ongoing, and of course, some of those resources will be tapped into for incorporation of the new data sources, and I'll talk a little bit more about that later. So another step is for policy analysis, is to work collaboratively with the PCMCH, so the Provincial Council for Maternal and Child Health, and this is something that we are working on. It's to be addressed. And lastly is to provide scientific guidance, advice, and program evaluation for the initiative to the BORN executive team. So the Congenital Anomalies Committee works closely it works towards a proposal that was put into the Public Health Agency of Canada, their CCASN, the Congenital Anomalies Surveillance Network. And we put in a proposal, and there's now a contract in place to develop the framework for improved province-wide surveillance of congenital anomalies in Ontario. So this is a 3-year proposal that's gone in and a contract in place, and now we have a priority to improve the province-wide surveillance congenital anomalies ascertainment, but that's something that the committee, of course, is doing as well. So this extra support feeds nicely into the committee's work. So we want to make it a priority to obtain complete congenital anomalies data for Ontario. Another thing we'll do as part of this contract is to then in turn take the data we collect and transfer certain variables to the Public Health Agency CCASN committee. So these are 16 national variables that we'll be delivering to the Public Health Agency. BORN has also developed a PIA, a Privacy Impact Assessment, so that we can share this data. So just to give you another background for what the current state of the data in the BORN system, we've incorporated these different sources of data into the system. So these are from the main sources from NIDA, so representing 109 hospitals submitting, as well as the Fetal Alert Network, so 5 hospitals or more submitting, and the Prenatal Screening Ontario data. So that's now fed into the BORN system, and we're looking to add 2 more sources of data. We took a look at the current status of the data in the BORN system, and we understand fully that there are going to be gaps in this ascertainment, and an assessment was made stating that we cover approximately 60% of the congenital anomalies data in the province. So this is something that we're working to improve, to fill in the gaps, as well as to improve the quality for things like the different code system, and to avoid missing data that's collected and submitted to BORN by different organizations, hospital sites, and groups. And lastly, I've talked a lot about these additional sources, but just to finalize, this is the next task that we're focusing on, is to collect data from DAD, so from the Discharge Abstract Database, so that we can improve our ascertainment of the congenital anomalies in the BORN system, as well as what Anne mentioned is to get NICU data from the Level 3 hospitals. So that's going to be the data that's already collected by the Canadian Neonatal Network from CNN, but as well we're going to be collecting this data directly from hospitals, so we can also get the identifiers, as that's what's needed for BORN to do the linkage in the system. And lastly, we're looking at cardiac anomalies data from pediatric cardiology sites at Sick Kids in Toronto. So this is going to be a stepwise strategy. We're focusing on these 2 or 3 additional sources of data, but as we move forward in the committee's work and throughout the years with the FAC agreement, we want to, of course, look at additional sources of data that were examined in the environmental scan. So we hope to continue improving the congenital anomalies ascertainment as well as quality of data. And lastly, I'm going to turn you over back to Mari so she can talk about the committees as a whole.
Thanks, Sherry, and thanks, Anne, so much for taking the time to share the work that these 2 of many committees have been up to. So I just want to take this opportunity to thank everyone who is involved with these committees, with their subcommittees, and with their working groups. It is an incredible amount of work, both in time and experience, effort and output that these key individuals provide to really make a difference in the quality and the usefulness of what BORN is trying to do. So thanks to the members of the committees, thanks to the resource people and all the support that goes around the committees to keep all of this work moving forward. specifically the chairs and vice chairs carry a significant load in trying to pull together a very dynamic, diverse, and dispersed group of people to focus on these relevant and particular issues. For anyone who's listening who would like to get involved, we are often looking for new members for the committees. I think right now specifically there is a call for expression of interest for membership in the prenatal screening subcommittee, but you can always go to our website, www.bornontario.ca, www.bornontario.ca, to look for any calls for expression of interest, or send an email to info@bornontario.ca if there is a committee you have particular interest in. I guess one sort of sneak peek is you'll have noticed on our committee structure right back at the beginning is we have a maternal newborn outcomes committee, but we are exploring the possibility of a child and youth outcomes committee. So you'll remember from the very initial born presentation we talked about the cohort of babies coming live or being born this fall at the same time as our build going live, and wanting to follow those babies as they grow up, and we do need the committee infrastructure to support that growth. So we're just getting the work required to pull that committee off the ground at this point in time, but keep your eyes open if that's something you might be interested in, and we'll follow up on a subsequent briefing. We do email, sorry, just being clarification from Anne, that we do email out the calls for expression of interest using the same mailing list we use for these Born Ontario briefings. And so if you received an invitation to this, you can be confident that you'll receive the invitation to that as well. If I guess a couple of notes about participating in the committees. It is a voluntary position, and we are generally looking for a 3-year commitment for a position on one of those core committees and subcommittees as well, while working groups are more time limited and a little more ad hoc with respect to duration and expectations depending on the subject at hand. So thanks again to everyone who participated, and I guess at this point we'll open it up to questions. You can use the chat box on your top left-hand side of your screen if you have any questions for Anne or Sherry. I could try to answer them, but I'm guessing they're our experts in this case. Oh, and Joanne Harold, who is Vice Chair of the Maternal Newborn Outcomes Committee, is also available, so you can hear it directly from committee leadership if that's needed. So no questions at this point. We'll give it another minute. Okay, let's see if I can come up with a question. No, still no questions. So I'm going to put Anne on the spot here and ask her a question specifically around how the committee and how the chair and vice chair prioritize the work. We know there's an incredible amount of work to do and no end to the available questions. How do you know which ones to pick and choose and prioritize?
We actually had a fairly rigorous process for that. What we did was we polled the committee members at a face-to-face meeting, and we actually went over and said, you know, consider your clinical life and your administrative life and everything that happens in your workplace, and think about, you know, what questions would you like to know more about? What are the key hot topics? And so we developed a huge list. There were probably 50 or 60 things. The committee chairs and I met together, and we pared down that list, put like things together. We brought it back to the committee. We actually talked about these again. Then we looked at the data that we actually could have to inform those questions. And some we had data for and some we didn't. And so then we actually came back to the group and said, well, here's what we have data for and here are the questions. Then we did another priority exercise. And then the last meeting we actually settled on the 3 things that we were left with. So that's the process we went through.
Thanks so much. A couple of questions came in the interim. So a question as to when the next session on committees, so the next Born Ontario briefing around screening committees might be. We don't have a designated date for that meeting quite yet. The content of these Born Ontario briefings we do try to keep fairly fluid depending on what is a high priority to share. But I would expect to see it in the next 2 to 3 months. So either the next briefing or the one following after that, depending on the availability of those who are to participate. Next question, how do the committees interact with each other to set priorities? That's a great question. It looks like I'm going to be put on the spot for this one. So it's a very good question, and there are a couple of mechanisms by which this happens. For the screening committees, there's a, I guess you could call it a leadership team that involves the chairs, the resource people. I'm not sure if the vice chairs sit there, as well as PCMCH and Born representation, and that's a really useful environment in which those committees, subcommittees, and organizations can share priorities and make sure that the projects are aligned. For maternal newborn outcomes and for congenital anomalies, it really is the resource people who are a key part of that communication. We are looking to set up some type of leadership model like the screening committees have, but haven't formalized that yet to have draft terms of reference for it. But really we count on Anne and Sherry as living within the day-to-day of Born to communicate amongst themselves and between the committee chairs when required. We have had some ad hoc meetings of the chairs, especially after the inaugural meeting, to talk about it, but again have a little more work to formalize the communication between them. So I hope that answers that question. There's another question here. I'm just going to give me a second to understand it. I'm going to read it out loud and hope that Anne can answer it. Birth order does not indicate numeric in background. Okay, I think this is a specific question for the technology of Born around birth order. Okay, there's a question here. I'm afraid we're not in a situation or not in a position to answer because we don't quite understand it. But the person who did ask it, just please drop an email and we'll be sure to track down the information for you. I think it is specific to the Born technology, if I'm reading it correctly. With that, it's 12:45. I thank you all for again sharing your lunch hour with us to learn about the work of these very important committees, and look forward to following up with details around the screening committees who have also been incredibly active and engaged provincially. Have a great day. Thank you very much.